Dr. Leshner, thanks for having me here. Alan, I'm not used to calling you Dr. Leshner, Alan, so it's a pleasure. I don't have slides. And so I'm going to basically be a very obedient person, and Alan said, what is it that your agency is doing that is relevant for the opioid crisis? And I'm just going to start by highlighting something that Dr. Dasu mentioned, and, but in different terms. I think that what I just want to say is that obviously opioid use disorders, opioid addiction is an extremely lethal disease. So just doing off-the-cuff numbers, I was making them in my brain, we have, say, 70,000 people that die from overdoses in 2017, estimated, which majority, perhaps 50,000, die from an opioid, of which let's assume 80% of them had an opioid use disorder, and the other 20 were patients suffering from pain. Basically, considering what the SAMHSA numbers are of 2.1 million people that have an opioid use disorder, that comes to a mortality of 2% per year or 20% per 10 years just from overdoses, without considering all of the other causes that actually result in lethality in this population. And so when we're dealing with opioid use disorder, I think that we have to face it. We have a disease that is highly lethal, and the lethality also occurs relatively rapidly, as opposed to something that we have like tobacco, where it is a long, long chronicity before it actually kills you. And we need to understand that distinction, because the urgency to intervene is actually more acute when you have a disease that may kill you so rapidly. So within that context, what is it that we know that works? And we know that medications probably by far from every single study that has been done has shown to be providing the best outcomes. So whichever survey that you look at, how much do they protect you? If you're on medication, you are so let's put it the other way, if you're not on medication, you are 2.5 to 3 times more likely to die from an overdose of an opiate. So look at the effect sizes of these medications as it relates to mortality, and that's the only one that I'm going to be touching it here. So within that context, why is it that we're not using them? And there are 2 elements to it, and I'm going to be delineating it because as these are the aspects where we're focusing our resources. So one of them, yes, we know that there is, on the one hand, very much stigma, but there's also a structure in our healthcare system, or lack of, that actually leads to make it harder to provide these treatments. And so that is one element. The other element that we have to face, apart from the fact that we don't know exactly what percentage of patients with an opioid use disorder are given access to medications, but we know it's very limited, between perhaps 30 and 50%. And I'm being generous with the 50%, but let's be generous, 30 to 50%. So that's one question. What is it that we can do as an agency to improve that? And that relates to, of course, structure changes, because, and to the extent that we can address stigma. And then the other problem that we have with medications, even though they are much more effective than non-medications, the reality is that 50% of patients will relapse within 6 months of initiation. So another extraordinary important point on our initiatives is what is it that we can do for retention. So how does that bring our actions on? Number one, what is it from research that we can develop to expand access to medication? So in the area of implementations and services, we're focusing on 2 aspects of research. How is it that the healthcare system can be better able to provide, screen and intervene and sustain people on medication-assisted treatment? And how can they help in moving them towards recovery? That's one. How can we involve the healthcare system? Number 2, the justice setting. It is estimated that 1/3 to 1/4 of individuals that have an opioid use disorder go to the justice setting. And if we don't treat them, mortality is extraordinarily high. 56-fold, according to the United States, 100-something-fold, according to the United Nations. So we need to treat. And so what models do we develop in the justice system and in the health care system? A third element to it is we've come to realize that opioid use disorder are tremendously heterogeneous. So what determines the outcome is not just as influence, which is important, by the severity of the disease, which is crucial, but it's also determined by the environment of the individual. And we do know that if we just address it from the perspective of just severity without considering the support, that's not going to work. So an important question scientifically is, what is the level of support systems required to increase the likelihood that someone will be able to stay in treatment for at least 6 months, hopefully into recovery? And this then brings me to the fourth point that is an area of great priority for our institute, and that is of severity. So medications work, and for whichever parameter you look at, but the issue is, do they work across the continuum of severity? And do you justify putting someone on a medication like methadone or buprenorphine when they are in the early stages of an opioid use disorder? And we have no data to that respect. Another component, fifth element, is how long do you keep someone on medication-assisted treatment, and how do you transition that, and how do you call that into recovery? And so these are areas where we basically have very little data. We know certainly that less than 1 year or 2 years probably is insufficient. But is that influenced by the type of opioid use disorder that you have and your chronicity and the support systems that you get, and or comorbidity? And that is another aspect that we don't know much. Sixth question, we have 3 different classes of medications. How do we decide which patient may benefit optimally from one on the other? And the way that the patients are given these medications is based on the availability and their own preferences, but not on the basis of what may make the most biological sense. And then the last question that actually has been resonating in my brain, because I just read that article on the New England Journal of Medicine saying that by calling addiction, we're stigmatizing the patients. And what is just going around in my brain is, who is saying that? Is this the patients' opinion, or is it our opinions as academicians that state, no, you shouldn't, this is a stigma term versus no, it's not. And I think that ultimately engaging the patients in this discourse about how to optimally offer them medication, what are their needs and what are the difficulties that they face in sustaining treatment is the final one that I want to comment on. And I am 9 seconds left. And I've been looking at, I overpassed by 9 seconds, Alan. I'm as obedient as that.
That's terrific. I will take your 9 seconds and say terrific, extremely helpful. Thank you very much.